Now Tony's just arrived in from the ski slopes after injuring himself. Tony, what happened to you out there?
I was skiing down and my friend stopped in front of me and I ran in the back of it and went down.
Alright. Now, Paul, you were there and brought him in on the ski patrol. What position was he in when he was lying on the ground after the fall?
When I got there, his mates had taken the ski off, although the ski didn't release when he fell, and he twisted his left leg.
So the ski was still on which leg?
On the left leg.
Oh, still on the left leg, come off the right leg.
Yeah.
Alright, now Tony, just a few questions before we examine you. You got no allergies, any medical problems?
Just allergic to sulphur.
Sulphur, okay. And did you find that once we put the air splint on, this green thing on your leg, was that a lot more comfortable?
Relaxed, yeah.
It did?
Relaxed there.
All right. Okay, so we know that the air splint on has relieved a lot of the pain. So when Tony came in, I've already given him some pain relief, some intramuscular narcotics, in anticipation of him to release or let down the air splint and examining the knee. For all patients who arrive in with the air splint on for knee and lower leg injuries, they have an air splint on, and we have to let this down very slowly because it can be quite uncomfortable for the patient. Now, Paul, can you come around here and steady the boot for me, standing around here? We're going to let the air down slowly and gauge the patient's reaction because this can be quite uncomfortable. How's it feeling, Tony? Not too bad? All right. Okay, so it's down now, and we remove the air splint. Steadying the boot. Thank you, Paul. The next step in terms of injuries to the skier is removing the ski boot. Now, some people ask whether, in fact, we cut off these boots or remove them. There's virtually no indication for cutting off a ski boot. For starters, just on the purely trivial level, the skier will get very upset about destroying their boot, and also it takes a lot of force and be quite an involved procedure. Paul's pulling up the trouser leg, and we're preparing to release the boot, undo it as much as possible before we actually remove it from the injured leg. We undo the buckles, pull the tongue forward if possible. Now, have you got traction on the leg there, Paul?
Right.
And we just remove it one forward sweeping motion. Now we've got the boot off, now we proceed to examine the patient. He's got, Tony here's got tight leggings on, which look good on the slopes that make it very difficult to examine the patient when they come into the surgery. So we're going to have to ask him to remove these so we can examine his knee properly. Now we're totally removing the trousers so we can examine the leg, the site of injury properly. Now, Paul, the pain is in your knee, is that right?
Yeah.
Can you tell me or give me some idea where in the knee it is?
It tends to be behind and then just in the front section.
In the front section. Now, when you fell, did you feel any pop?
Yes,
or
I felt a crack or whatever you want.
A crack or pop. In which part of the knee do you think it occurred? In the inside, outside, towards the front or towards the back, or in the middle of the knee?
Probably in the middle of the knee.
In the middle of the knee. All right, on approaching the acute knee, after we've got an idea where the pain is, we know it's probably laterally and internally. I like to flex in there a little bit to gauge the patient's reaction. It's not too bad there. He obviously hasn't got huge hemarthrosis at this stage. There's not that much swelling. There's no break in the skin surfaces. Now I'm just going to very carefully palpate the knee to get an idea where it's uncomfortable. Anything back here, Tony?
No, it's fine, no.
Medially?
Yeah.
We've got a little bit of tenderness over the medial aspect on the joint line of the knee. Any tenderness down lower over the lower insertion, Tony? On the upper insertion, the medial collateral ligament. Anything posteriorly? No. Anything laterally? Nothing over here, Tony? Right. We're going to try Lachman's test to test for the integrity of the cruciate ligaments. Just bend a little bit, Tony. Holding the femur there with the knee about 20 degrees flexion. There's very little motion forward or backwards tibia on the femur. So the cruciates would appear to be intact. We're now going to test for the integrity of the collaterals. A little bit of laxity. Sorry, is that uncomfortable, Tony? With tenderness there on springing the medial ligament. Not so much on springing the lateral. So we have a knee. The pain was localized in the middle of the knee and laterally, but in fact on examination we found it lies medially. So I suspect at this stage that we've got a sprain in the medial collateral ligament of the knee, which is in fact the most common ski injury we see, accounting for about 20% of all injuries. In fact, the knee is about 25% of all ski injuries seen. This comes up in all series. However, the patient's still cold, he's coming from the cold and the snow, he's in fact effectively had an ice pack on his knee, so I don't know what's going to happen to this knee later on when he warms up back in the lodge. It could end up with a hemarthrosis, and I think it's only the proper thing, and doing it carefully and given the clinical situation we're in, to get an x-ray, good quality x-ray of the knee at this stage. That's what we're going to do now. Well, today, or 12 hours later, we have Tony. We examined him yesterday for his knee problem and made a provisional diagnosis of a sprain, if not a partial tear, of his medial collateral ligament of the left knee. However, we've had the opportunity to review Tony's knee. I'm going to ask Tony what's been happening to his knee over the last 12 hours. What have you been feeling?
Feeling a bit of discomfort as far as the swelling is concerned. Came fairly big overnight, and just pain on this right-hand side and inside the knee.
Yes. So you think the fact it's got worse overnight?
Slightly worse, probably because I was lying in the same position all night, actually on my back.
And you did use the ice packs in the way that we described. Right, so we have, when just looking at Tony's knee here, there's an obvious effusion in the suprapatellar area, and he's still very tender medially, not laterally, a little bit posteriorly, and so he still has an acute knee injury now with an obvious effusion, almost probably a hemarthrosis, making it very difficult, again, to put him through the full range of movements and using all the conventional tests to determine what the exact cause. However, I think it stresses the importance of following up on these knees and being able to make or strengthen up our provisional diagnosis. Presence of a hemarthrosis, I now suspect that not only has he got a tear of the medial collateral ligament, but he's also got a tear of the anterior cruciate ligament. And I think Tony would be best advised to have arthroscopy for this knee now, and so they can get a better idea and a much more accurate idea of what's going on with it, because he's going to require arthroscopic examination and probably some intensive physiotherapy, if not some intra-articular ligament repair. So we're going to strap him back up. I'm just putting back on the modified Robert Jones, although ordinarily I would put on a back slab, a plaster back slab, but Tony seems to think this would be more comfortable for him, and I've organised for him to be seeing the sports medicine clinic in Sydney when he gets back there in the next 24 hours. Gail's come into the surgery, and she's come in today reporting a thumb injury. Now Gail, do you remember falling at all, or do you know when this thumb started to bother you?
Only when I started skiing, kept
yes.
forward all the time.
You did. So that was yesterday. So you fell several times yesterday. Do you remember the sort of way you were falling yesterday? Was it forward, backwards, sideways?
Forward, backwards, sideways, either way.
All different ways. Mainly forward. All right. Well, look, Gail's got a very swollen thumb here, and with the thumb injuries that come into the ski clinic, they always classically present the following day. The usual story we get from the patient is that they've fallen forward onto the outstretched hand with thumb in abduction and extension, reaching a tiny little ligament here in the thumb called the ulnar collateral ligament. The pistol grip stock was designed to prevent ski injuries, but in fact it probably causes more. The stock is not able to separate from the hand and keeps the thumb quite separate from the rest of the hand, and sets a scenario for the skier's thumb injury to occur. We think the stock with a strap should be used, with the strap hanging down and certainly not around the wrist, so that when the skier falls forward, the stock can completely separate from the hand. Lose the stock and save the thumb. Now Gail has described the area of maximum tenderness just on the